Dr. Thoreson, he's a board-certified urologist with urology clinics in North Texas. He received his Doctor of Medicine from the University of Texas Health Science Center in San Antonio and completed his residency at the University of Texas Southwestern Medical Center in Dallas. He specializes in treating a wide variety of urologic conditions in both male and female patients, including kidney stones, enlarged prostate, which is BPH, urinary incontinence, erectile dysfunction, and low testosterone. We have a lot of great content to go ahead and cover tonight. So Dr. Thoreson, I'll go ahead and turn it over to you so you can get it started for us.
Great. Katie, thank you for the introduction, and thank you everybody for taking the time out of your schedule to have this talk with us. Tonight we're going to be going over various parts of the prostate and also the contributing factors that lead to urinary symptoms. So let's just jump in here. We're going to start with an anatomical background here. Basically, the prostate is an organ that sits deep within the pelvis. It's roughly sized the same as a walnut. It's not always true. All prostates are actually unique, like snowflakes, I guess. So they're not all the same size. It's kind of confusing, but the prostate actually wraps around the urethra. That specific part of the urethra is the prostatic urethra. And I always kind of say that it's really where two rivers come together, and that's why, you know, both ejaculation and urination all take place through the same organ, the phallus. What they mentioned here at the bottom is that the prostate grows to a normal size in the early 20s, and then over time, it's pretty constant that as we age, our prostates will also grow in size as well too. So, you know, with regards to the various conditions of the prostate, there's the hyperplasia, which is what we're going to be talking about tonight. So that's the benign growth of the prostate. But then there's also potential conditions of the prostate, and that classification is really just prostatitis. And then there's prostate cancer. And we're not really going to get into that too much tonight, but we will kind of talk about it briefly. So just, you know, with regards to obstructive urinary symptoms, we pretty consistently use the term benign prostatic hyperplasia. And really, when we say that, what we mean is that it's not a cancerous condition, so it's a benign growth of the prostate, and then the prostatic is of relation to the prostate. But then the hyperplasia, that's just a term we use when we talk about glands that proliferate or grow in time. You know, what they state here is that benign prostatic hyperplasia can lead to bladder outlet obstruction. And that's, you know, essentially the focus of tonight's talk, is, you know, kind of ways to address that. So when we say BPH or benign prostatic hyperplasia, it's not necessarily prostate cancer. We do keep that in mind, or it's kind of one of our focal points, is to make sure that we've, you know, kept that into consideration, but generally it's not a cancerous condition. And then the other thing is there's not a causal relationship with benign prostatic hyperplasia and prostate cancer. They're two distinct entities. And then BPH symptoms are actually similar to those of cancer, although that presentation for prostate cancer in the era that we live in now, where we screen for prostate cancer, isn't all that common, although it could happen. And then also, just like I said, that these are, you know, two separate entities that can exist concurrently or at the same time. And when we talk about PSA levels, so PSA is the test that we use to screen for prostate cancer. There can be some overlap there with an elevated PSA and hyperplasia of the prostate and an infection of the prostate or prostatitis. So it's kind of hard. PSA levels don't really tell us anything specifically, unfortunately. It could include any or all of those conditions. So it's kind of up to us to kind of tease that out and figure out what's actually going on with that. So these are the mechanics of obstructive urinary symptoms in relation to hyperplasia of the prostate. So over time, the prostate will grow and enlarge in many, if not most men. And that does cause impingement of that prostatic urethra, or that inner part of the urethra from within the prostate. And this is very true. The bottom segment or bottom paragraph here is that the prostate size does not correlate with the degree of severity of symptoms, which is so true. So, we always say big prostates don't necessarily obstruct. And same thing with small prostates, they're not necessarily wide open. It all comes down to that inner channel of the prostatic urethra and the secondary impingement of flow of urine. I like this slide because they actually talk about everything, which in truth of all of these, I really see obstructive urinary symptoms as the one right in the center, the weak flow, and that's really what we try to dial in. Every single time you come into the office, we're always asking you to fill out those forms, but those forms actually let me know exactly which quadrant we should focus on. And really for hyperplasia of the prostate, that's kind of that weak flow or obstructive urinary symptoms. When we talk about painful or burning with urination, that's actually kind of a different condition. That's actually an infection is really what comes to mind there, although we do think of other things as well too. And then a pure inability to urinate, that's the urinary retention potentially hurting your kidneys, which isn't common, thankfully, but is a possibility. And then the frequent urination, that's the kind of third part to a lot of this, where overactive bladder disease sometimes exists, concurrently with hyperplasia of the prostate. And then urinary retention is another part of all that as well too. So what they don't have here, and the one that plagues a lot of us, is the nocturia, or waking up at night, and this is all kind of within the spectrum as well too. So these are some statistics that they like to show, and I'll just kind of read some of them with you guys. But up to 95% of men with moderate symptoms aren't happy and don't want to spend their lives like that, and 51% of patients say that BPH interferes with their aspects of normal lives. In truth, when it comes down to statistics, one of my favorite ones is really essentially just talking about the frequency of obstructive urinary symptoms, or really just benign prostatic hyperplasia. And it was told to me during my training that, you essentially could take someone's age and apply a percent point next to it. And that's the frequency at which men of that age group will actually have, hyperplasia of the prostate. And it does turn out to be rather true, that kind of age-old adage. And these are some other statistics here and this is kind of what we were getting at. So the one on the upper right, where it says that, 90% of men by age 85 have obstructive urinary symptoms, and then 50% of men at the age of 60 do have obstructive urinary symptoms. So, the gift of getting older is that, yes, we do get to hang around on Earth longer, which is fantastic, but certain things do change over time. And this is kind of one of those almost certainties here, where hyperplasia of the prostate is quite common. So enough of beating a dead horse here. When we go to examine patients, there's the digital rectal examination, which does give us some sensation of the volume of the prostate, but that's not actually a reliable indicator of the volume of the prostate. For me, in my practice, when we talk about physical examinations of the prostate, that's really more to evaluate for prostate cancer. So that's one of the kind of our backbones for really doing a thorough evaluation in the kind of evaluation of prostate cancer. So that's one of the things that we do. For urinary output testing, you can certainly do a voiding velocity to try to find out what somebody's peak flow is. I don't routinely use that in my practice. You'll find out that all the studies that you've seen or might have seen in this space, we do talk about maximal velocity, and that is actually very important. With regards to the post-void urine volume testing, we do that quite frequently in our office. I think that that's a really big aspect in that. If you do find out that somebody's retaining urine, they could potentially be hurting their kidneys on that. So the AUA symptom score, or the IPSS, which are all pretty much the same for the most part, as well as the quality of life questionnaires, those are critical to assessing, symptoms upon, initiation of treatment or initiation of evaluation, but then also tracking progress over time too. So those are kind of reliable indicators. And same thing with all the clinical trials that were, performed in the setting of evaluating and approving the drugs that we use in this space, that's kind of the cornerstone for how we judge success in this space. So with regards to treatment options, we're going to start from most conservative to actual therapeutic options, and then ultimately that's kind of what we're getting at tonight is kind of the therapeutic options. But most men actually stay in the conservative space, but with procedures such as this, it does wind up kind of presenting options that one may consider a little bit earlier than they would when it comes to the procedures that we do in the operating room. So with regards to behavioral modification, a lot of times you can kind of tweak some of these symptoms based on fluid intake and fluid management based on the time of the day. Trying to work on management of bladder volumes and what you take in, stuff like that does actually help more with the overactive bladder disease, is what I would say in that space. But then for first-line therapies, the medications are probably the most common and most familiar that people engage in this space. But then, tonight we'll talk about some of the other stuff too. So the resumed water vapor therapy is really what we're here to talk about tonight. And then the permanent implants is alluding to a procedure called urolift as well too, whereby permanent implants are placed within the prostate. And then there's for surgical procedures in which patients would need to be under a general anesthetic. There's green light laser prostatectomies, there's TURPs, and then for appropriately selected patients, there's the simple prostatectomy for hyperplasia of the prostate. With regards to phytotherapies or alternative treatment options like plant-based options, saw palmetto has been evaluated extensively, and I get this question pretty much every day where people ask about the utility of treatment for super beta prostate, saw palmetto, any of the over-the-counter medications or not medications but vitamins, or any of the late night advertisements that you might have seen. They're all regarding saw palmetto. And in randomized controlled trial settings, it does no better than a sugar pill. Unfortunately, we wish that there was something good that is plant-based, and that's essentially what phytotherapies are. But it just didn't actually work out. So we don't really spend much time talking about this just because it's kind of more of a marketing for, unfortunately, people who are really just looking for some help from kind of a homeopathic standpoint. I wish that there was something, but there's really nothing that I would endorse. With regards to watchful waiting, that is something that quite a bit of patients do where, essentially it's really just kind of putting off, the management of this condition is kind of how I see it. It's not really meant for kind of long-term use. It's really kind of more when people are, in my opinion, when people are kind of first kind of evaluating options, this is kind of where they're at, is what I would say. So with regards to alpha blockers, this is our most common medication that we give in this setting. There's about 6 drugs or so in this class. Things that people talk about, when they first start treatment is sometimes a drop in blood pressure, specifically what we call as orthostatic hypotension. So if you stand up too fast, you could drop your blood pressure and you can get lightheaded in those situations. You can also get a pretty bad stuffy nose. Alpha blockers are the exact opposite of Sudafed. So if you've ever used a drug like Sudafed, you know that your nasal passages open up and you can breathe a lot easier. And alpha blockers are kind of the opposite of that. And then consequently, with Sudafed, you do actually get some urinary obstruction in certain settings. So if you haven't already come across that, please stay away from Sudafed if you do have any kind of obstructive urinary symptoms. But then for we call them 5 ARIs, or the 5 alpha reductase inhibitors. They essentially slow down or stop the synthesis of a compound called dihydrotestosterone. And that's really the active compound that leads to hyperplasia of the prostate. And when that kind of agent is removed from the body, you'll actually get involution of the prostate. So you'll get shrinking of the prostate. The downside to it is that it is a very slow acting process where it's not an immediate process, whereby the alpha blockers that actually, essentially set in, or you would get maximal effect roughly 2 weeks afterwards. For 5-ARIs, that's something like 3 months, and then even you get more improvement on top of that at the 6-month mark. And these two drugs can be used concurrently. One of the biggest downsides is that there is some erectile dysfunction with the 5-ARIs. That's not for everybody, but it is possible. And then some people do report a lower sexual drive. The ejaculatory dysfunction I find to be more prominent with my patients on alpha blockers. It's kind of known to have retrograde or anejaculation is what we say. And then for the 5-ARIs, there might be some breast tenderness or breast enlargement that happens with that. So the Rezum water vapor therapy, which is really what we're here to talk about tonight, is an outpatient therapy that we can do in the office. And we don't need a general anesthetic, which is a really attractive option. The other thing that I find to be very attractive about it is that when we do it in the office, there are no, essentially facility fees, at a hospital or a surgery center. So overall, there's, in my opinion, and I have not really looked at the model associated with it, but this is just my own intuition that, overall, it's kind of easier on the healthcare system when something like this is performed over, say, like a TURP procedure or any of the procedures that we do in the operating room. So that is a really attractive thing, in that the healthcare system as a whole has less of a strain on it for procedures like this. As far as the side effects, these are real and really cannot be understated, that there is some painful urination that takes place afterwards. And it doesn't really say it in here, we'll go over it later, but there is a period of time in which the energy that is applied at the time of Rezum treatments, that the body winds up going through some changes. Where it does a pretty large cavity where that inner channel used to have been. One of the other attractive things about Rezum is that there's improved preservation of ejaculatory function. And depending on the needs and desires of the patient, that can actually be a rather important kind of side effect of treatment. With regards to the other side effects, I'll just kind of list them. Blood in the urine, blood in the semen, decrease in ejaculate volume, urinary tract infection, inability to urinate or completely empty the bladder, or urgent need to urinate. Thankfully, the majority of these are actually transient. And yes, this is true, but this is also true for pretty much any of the surgical procedures that we do for the prostate. So this is going to be the kind of rundown of kind of what takes place during the Rezum. So I'll just go ahead and start the video here.
Rezum water vapor therapy is a non-surgical treatment for BPH. Rezum uses the natural energy found in steam to shrink the prostate. In just seconds, this precise technology destroys enlarged prostate tissue while minimizing any effect on surrounding tissue. Rezum is a potential alternative to drug therapy, permanent implants, and surgery. It preserves sexual and urinary functions, and it's clinically proven to safely and effectively reduce BPH symptoms. Potential side effects include painful urination, blood in the urine or semen, pelvic pain, and urinary frequency, retention, or urgency. The procedure is performed right in your doctor's office or outpatient center. You do not need general anesthesia for the procedure, and Rezum therapy lets you quickly return to normal activities. Talk to your doctor about Rezum if you're no longer comfortable with your BPH symptoms. Drug therapy isn't working for you. The side effects from drugs are impacting your quality of life, or you don't want to have surgery or get an implant.
basically, the long and short of it is just, in the office, there's a series of treatments. We probably average about 4 treatments in most men. And what we do is we essentially just instill steam therapy into the kind of obstructive portions of the prostate. And then over time, there's that involution of that area in the prostatic urethra that take place. One of the things that mentioned was that, it's real quick return to normal function. I would say that everybody's different on that though. So, with regards to when everything is, completely reabsorbed, I would say that there's a range on that. And some men get back to it, within 2 to 4 weeks, which is kind of, in my opinion, kind of best case scenario, or at least in my practice, that's the way it's been. I feel like on average, it's more 6 weeks, potentially even 8 weeks. But, it is a process by which, when we talk about retreatment rates, it is one of the best on that. So I do really like the durability associated with this. Let's go ahead and go to the next slide. All right, and this is another video.
I found out that I had BPH. My symptoms were a slow stream, and I would wake up frequently in the middle of the night. I first heard of Resume when I was researching enlarged prostate and the procedures to repair it, to fix it. And Resume was one of them. The more I researched Resume, it was the latest and greatest technology, and I want to be part of new technology. I think technology is good. My experience with the Resume procedure was very good. After the procedure, I was a little worn, a little tired, and the next day I felt fairly good and was able to get up and get around.
Since Joe's Resume procedure, we're able to spend much more quality time together, fewer interruptions, and we're just happier as a couple. The Resume treatment has made a very big difference in our life.
All right, so the prostatic urethral lift treatment, or urolift treatment, it's an outpatient procedure. It's actually pretty similar just in the setup for Resume, but the downside to it is that there's a pretty high retreatment rate. This is where their studies kind of left things at the 5-year mark, and I felt like that was actually true in my practice. And for those of you that might have heard me talk about it over the years, I had actually placed a lot of confidence in this actually being a durable treatment for my patients. So I was pretty enthusiastic about it for a while until, the 5-year data actually came out. And that's why I've essentially kind of transitioned pretty much my entire practice over to Resume. And although there are kind of more side effects initially after the Resume treatments compared to a urolift, the durability is really what drives my decision to actually do essentially exclusively Resume these days, is how it's been. Let's go to the next slide. And then green light laser therapy is another treatment offered by Boston Scientific, that the organization that's hosting tonight's talk. I personally don't do a lot of green lights these days. I did hundreds of green lights during my training, but from what I've seen, just in terms of talking to patients, I feel like compared to other treatments in this space, there's a little bit more burning with urination afterwards. But for certain patients, this still is my method of treatment. So for really large prostates in men who are not great candidates for simple prostatectomies, I still do green light laser therapy, but I just don't do it a whole lot. I also don't like how there really isn't any tissue available for analysis as well too. So I do like when I have the opportunity to be able to evaluate prostate tissue, just so no prostate cancers get missed. As you look at the side effects of some of, or from this treatment, it's pretty kind of a long list, but a lot of that is pretty similar to, the other treatments in this space. But the one thing that I'll say is that I feel like there's a little bit more burning with urination with this treatment. Let's do the next slide. All right, and this is going to be another video on green light laser therapy. All right, so this is a procedure called TERP, and this is a procedure that we've actually been doing for close to 100 years now. So it's a rather old procedure, but we've actually gone through quite a lot of revisions associated with this procedure. It does get deemed as the gold standard for treatment of benign prostatic hyperplasia. I also find that to be true in my practice too. I do quite a bit of TERP procedures. There's some benefits to it. We can sample the tissue. In rare occasions, we can also send the tissue for culture if needed, if somebody's been suffering from recurrent prostatitis. The durability is quite good, about 5.8% at the 5-year mark. Essentially trends, they actually have 10 and 20-year data on some of this stuff, and it kind of comes pretty close to that 1% per year in terms of retreatment, which is rather good, I would say. And that's kind of why, the resume therapy, I think, is actually pretty impressive in that, their 5-year data mirrored that and actually beat it. You have to kind of take all that information with a grain of salt, but at the very least, it's trending in a very similar direction to TERP on that. So very impressive. But, what we do say, though, with regards to TERP is that people do lose their ability to ejaculate. That's one of the great things about resume is that you actually get to preserve ejaculatory function moreover than you do with TERP. And of course, all procedures in this space will have some association with, ejaculatory changes as well. Let's go to the next slide. So when they say prostatectomy, that's a little confusing because there's a radical prostatectomy and a simple prostatectomy. So really what they're saying here is a simple prostatectomy. And then we do this for rather large prostates. So generally for prostates greater than 80 grams, probably more common in 120 gram prostates and larger. And by reference, 20 gram prostate is kind of what we all had in our 20s or something like that. And then a 40 gram prostate is probably our more routine average size prostate. So again, these are for 80 to 120 or greater gram prostates. When we do it, it's generally kind of a rather extensive procedure where you're in the hospital with us for anywhere from 1 to 2, maybe even sometimes 3 days. And it is an abdominal procedure, so it's kind of an extensive one. But if you look at the retreatment rate, it is quite good, especially given the degree of obstruction that was present that brought these patients to the operating room. And again, the ejaculatory changes are there as well too. So let's go to the next slide. So for insurance coverage, Katie, do you want to talk about any of this?
I'd be happy to. So essentially with Resume, all Texas payers go ahead and actually cover with insurance. I will say there is Amerigroup Healthcare. I believe that's like 2% of Texas population that has some issues. And then if you have a certain type of Blue Cross Blue Shield, you may also have some issues. However, for the most part, insurance does really well with coverage for this.
And then, so just as kind of a recap, in terms of all the treatments that are out there, just from start to finish, when somebody's actually walking through their symptoms and really just trying to evaluate things, that's really where watchful waiting seems to kind of take place. And then for first line therapies, there's the medication, or kind of viewing this probably maybe a place that you're at. And then, in that same space of first line therapies are, these treatments that we talk about, the office-based treatments. And then for surgical procedures, we do reserve those more for kind of the more severe cases, or kind of situations in which we're actually looking for a very definitive treatment here. So let's get to the next slide. All right, so next steps, although these webinars are quite helpful, they're really not, essentially rendering of care on that. So really what they recommend is that come meet with your urologist and, see which treatments actually fit for you. And that's kind of the good thing about these evolving technologies that we've had come onto the scene over the last 10 years, is that, previously we never really had options like this. So it's nice to just have extra tools in your tool belt. And that's really what this represents, is what I would say.